I'm Sarah Grier. I'm a respiratory therapist at QHC. So respiratory therapists focus on everything pulmonary, so everything with the lungs, and then in turn with the lungs, the heart. So when you come in short of breath, if you have asthma or COPD, heart failure, our COVID patients in the ICU or emerge that come in and need a little bit of support, or newborn babies that need a little bit of CPAP or maybe put on a machine for a little bit to kind of transition themselves back into this world.
COVID hits, and it is a respiratory disease. As they say, when you can't breathe, nothing else matters, right?
Exactly. So yes, COVID very much affects the lungs, the advanced pneumonia that a lot of people get. So as like you said, if you don't breathe, you don't have oxygen, that compromises your heart, that compromises your brain. Every body system revolves around having oxygen. So when your lungs are compromised, your whole system really takes a hit. So we work to kind of optimize what lung function you do have at the time and kind of help heal you along the course of the COVID. For example, our patients on 25, a lot of them just need a little bit of oxygen because their oxygen saturations are low because they have some inflammation and some fluid in their lung. So by giving them some oxygen, they kind of, their other systems can kind of work more optimally to help them heal. And then as they progress, we do things like putting them in a prone position, so lying on their belly and doing different things to allow their lung to heal as best possible.
When you reflect on your experience caring for COVID patients, particularly in wave 3, when we've seen a lot more of COVID activity at QHC hospitals, first of all, what is most concerning to you? And then secondly, what makes you most proud?
Probably the most concerning thing that I have noticed, especially with this third wave, is these patients with, especially the variants I find, are coming in much sicker. They're much younger. This isn't an old people's disease. These are otherwise healthy individuals that are coming in, and maybe they've come in early in their disease progression. Sometimes they're coming in a little bit too late, and we're really having to fight to help them to kind of make it through COVID. But these variants seem to be spreading so much faster than the original strain, and that's really concerning to us. And the other thing I'm really noticing that a lot of these patients, because we've gone through a year of quarantine and lockdown and masking, they've kind of, even the patients that have COVID that have ended up in hospital are up on the floors and they think, it's not really that bad. It's not really that bad. And then all of a sudden we're in ICU and they think, oh my goodness, this is a lot worse than I thought it was. They don't realize how sick they really are, because we're managing sicker patients on the floors to help with ICU overcapacity, that now all of a sudden they're in ICU and it kind of clicks the light bulb and they think, I'm a lot sicker than I really thought I was. So as an RT, we help manage these patients on the floor, and we're also part of the critical care response team. So we kind of go and we monitor these patients on the floor. Once they're needing a certain amount of oxygen on the floor, we're pretty involved in their care. We provide support to the 25 staff and the emerge staff to kind of determine what's the best place for these patients. And then we can help deliver certain types of therapies up on the floor to see if we can maybe keep this patient here, or maybe they're better suited to go to the ICU for a more extensive workup. I think through, especially third wave and in general in the hospital, our team at QHC really is a pretty stand-up group of people, especially with this third wave. We've had a lot of redeployed staff from my friends that I've worked with in the OR. They're now getting put into the floor. The staff over in PACU are actually now caring for ventilated patients, which a lot of them are ex-ICU nurses, but that's something we've really been all pushed to step out of our comfort zone a little bit, and not necessarily outside of our ability, but sometimes we're taking on things that are a little more challenging. We're having to ask for support. Our team is really good at supporting people that aren't really used to that kind of acuity of patient. I think too, with these Toronto patients, I think a lot of people in our community are frustrated about, oh, well, Toronto's taking up our acuity. And I think it's really important to remember that if the tables were turned and we were over capacity in Toronto headspace, if it was my loved one, if it was myself, my family, I would really want the opportunity for them to receive a bed elsewhere. And I think that's really important to remember. And for us, it also provides a little bit of a challenge. So for example, I took a COVID patient off life support on the weekend who only spoke Mandarin. So we were able to use Google Translate. We called his family. His family was able to translate to get him off the life support machine. But that's definitely something that we don't have to deal with daily in this area.
Right.
It's definitely a challenge for this poor patient that was intubated in Toronto, came down. So now he's waking up, realizing that not only has he been on life support for a certain amount of time, but he's now in a town that he's never even heard of, in a hospital where he can't see his family. He has no idea where he is, let alone the fact that he's sick.
Right, right. Really nice to meet you, and take good care.
Awesome. Thank you so much.
Okay, thank you.